Anytime the body sustains an injury, its immediate biological imperative is to restore normal structure and function. If conditions are ideal, the injured tissue attempts perfect cellular duplication, flawlessly multiplying to close the defect completely and seamlessly. We call this precise restoration pathway regeneration. Because the body replaces damaged cells with exact replicas, the process leaves zero trace of the original injury. But when massive tissue loss makes perfect duplication impossible, the body immediately shifts to an emergency patch protocol. This secondary pathway is repair. The body abandons exact replication and instead replaces the damaged area with fibrous scar tissue, a process known as fibrosis. The path a wound takes, perfect regeneration or fibrous scarring, is not random. It is strictly governed by the inherent mitotic classification of the injured cells and the physical geometry of the wound itself. To understand whether a tissue can achieve perfect regeneration, we have to look at where its cells reside within the standard cycle of division. This diagram maps the standard cell cycle. Cells are categorized into 3 distinct groups based on their ability to navigate these phases. First are labile cells, found in the skin epidermis, the mucosal lining of the gut, and bone marrow. These cells divide continuously throughout life. Their constant state of division makes them prime candidates for perfect regeneration. Next are stable cells. Cells in the liver, kidneys, and fibroblasts typically rest in the G0 phase. They are not actively dividing, but they can be recruited back into the active division cycle when stimulated by an injury. Finally, we have permanent cells. These include neurons in the central nervous system and cardiac muscle cells. After birth, they become terminally differentiated and are permanently locked out of division. Because permanent cells cannot divide, any structural injury to them carries a clinical absolute. The healing outcome will always be repair and fibrosis. The mitotic capacity of a tissue provides a hard biological limit. It dictates whether the architectural outcome is fully functional tissue or a rigid structural scar. When the cell cycle prevents perfect regeneration, the body deploys an alternative structure called granulation tissue. This is a highly vascular, temporary connective tissue scaffold. We can track the formation of this scaffold across 3 sequential phases on this timeline. Phases 1 and 2 manage the acute inflammatory response. Neutrophils and macrophages infiltrate the site to clear out bacteria, followed immediately by proteolytic enzymes that dissolves the necrotic tissue debris. Phase 3 is the crucial ingrowth or organization phase. This step requires 2 simultaneous biological processes. The first is angiogenesis. Mediated by growth factors like VEGF and BFGF, the body grows new, intentionally leaky blood vessels to rapidly supply emergency nutrients to the area. The second is fibrogenesis. Around day 6, fibroblasts proliferate across the site and begin depositing dense structural collagen. Granulation tissue is the body's emergency architectural protocol, trading perfect physiological function for rapid, vascularized structural integrity. Moving from the microscopic to the macroscopic, the physical geometry of an injury dictates the scale of this granulation response. Skin repair provides the clearest baseline. Healing by primary union, or first intention, occurs in clean, surgical incisions where the edges have been sutured together, resulting in minimal tissue loss. By artificially bringing the edges together, the surgeon creates a very small microscopic defect. This requires only a small blood clot to seal, followed by rapid epithelial growth over the surface, leaving a thin, neat, linear scar. Secondary union, or second intention, happens in large open wounds, ulcers, or infected defects where tissue loss is extensive. Because the gap is too large to simply bridge with a clot, secondary union introduces a critical mechanical requirement: the physical contraction of the wound edges. The body utilizes specialized cells called myofibroblasts. Acting like microscopic muscles, they grip the separated tissue margins and physically pull them inward. While myofibroblasts can reduce the size of the defect by up to 70%, bridging the remaining gap requires a massive volume of granulation tissue, ultimately leaving a large, irregular scar. Mechanical wound approximation directly dictates the necessary biological response. Minimal gaps require minimal patching. Large structural voids demand aggressive cellular contraction and massive fibrosis. These core rules of clearance and scaffolding apply far beyond the skin. Internal tissues adapt the exact same principles to their specialized environments. In bone fractures, a hematoma forms first. This blood clot is gradually replaced by a bridge of granulation tissue and cartilage, creating what is known as a soft callus. Next comes the hardening phase. Osteoblasts migrate into the soft callus and lay down unorganized woven bone, transforming it into a rigid osseous callus. Finally, osteoclasts arrive to shave away the excess woven bone, carefully remodeling the area until it returns to its original lamellar structure. The nervous system presents a stark contrast. As established earlier, neurons in the central nervous system are permanent cells, entirely incapable of division. When the brain or spinal cord is damaged, it heals via gliosis. Instead of fibroblasts laying down collagen, astrocytes rapidly proliferate to fill the gap, forming a functional brain scar. Peripheral nerves operate differently. If an axon is severed, it can sometimes regenerate through Wallerian degeneration, where new axon sprouts follow a surviving Schwann cell pathway back to the target muscle. Even in highly specialized systems like bone and neural pathways, the fundamental algorithm of debris clearance, temporary scaffolding, and cell cycle limitations strictly governs the final architecture. Understanding the normal sequence of healing allows us to identify what happens when the protocol is biologically or chemically interrupted. Local bottlenecks occur at the site of the wound itself. Active infection is the single most common cause of delayed healing, followed closely by poor vascular supply, or the presence of foreign bodies like dirt or retained stitches. Systemic failures disrupt the building blocks of the process. A deficiency in vitamin C or zinc halts collagen synthesis, while systemic glucocorticoids or steroid drugs actively suppress the vital initial inflammatory phase. We can see the architectural failures of hyperproliferation in this comparison. On the left is a hypertrophic scar, which is thick and raised but stays strictly confined within the boundaries of the original wound. On the right is a keloid, where massive bulbous scar tissue proliferates aggressively and grows far beyond the initial borders. Other complications are strictly mechanical. Wound dehiscence is the mechanical bursting open of a previously closed wound, representing a catastrophic failure of a primary union, most commonly seen after abdominal surgery. Conversely, cicatrization occurs when wound contraction becomes extreme, severely limiting surrounding joint movement and causing physical deformities. Pathological healing is rarely random. It is the predictable consequence of a specific phase, whether inflammation, collagen deposition, or contraction, being chemically starved or artificially overamplified. Finally, we must look at highly specific pathological deviations. In conditions like sarcoidosis, the body responds to injury by forming unique clumps of immune cells called granulomas. Looking closely at a histological slide of a sarcoidosis granuloma, we can identify distinct microscopic markers, like this asteroid body, a star-shaped inclusion trapped inside a giant immune cell. You may also find shaman bodies in the same tissue, which appear as laminated, onion-like structures made of calcium and iron. Tissue healing is a strictly conserved biological algorithm. Mastering wound pathology requires recognizing the exact cellular constraint, systemic bottleneck, or mechanical failure that forces the body off the path of perfect regeneration and into the realm of repair.